Welcome everyone to the first hybrid colloquia of 2022 and 2021 for that matter. To introduce our speaker today, Dr. Sroka from Munich, I'd like to call Tyler, who is the president of the Student OSA chapter, and Dr. Sroka is here as the traveling OPTICA lecturer. So Tyler.
On behalf of the UMass Lowell Physics Department, I'd like to welcome Professor Ronald Sroka to the colloquium, Physics Department colloquium, and as part of the OPTICA traveling lecturer program. Professor Sroka is the head of the Laser Research Center at the Life Center of the University of Munich, where his research is focusing on laser applications in medicine, such as fluorescence diagnosis, photodynamic therapy, and laser surgery. And he will be giving this talk today on the laser-induced lithotripsy, a never-ending development. So please welcome Professor Sroka.
Thank you very much. So I feel very honored to become a traveling lecturer by OSA or OPTICA right now, and that I'm right now here. And yes, so I was asked to give some lectures here, and we decided that laser-induced lithotripsy would be one possible lecture. And lithotripsy, laser-induced lithotripsy, is a never-ending development. So it starts long time ago, but we are still in progress to make new inventions there. So first of all, I would like to show you our campus in Germany, or this is Munich is behind here, and this is in the southwest part. This is the campus of the medical department. This is the hospital of roughly 2,500 beds. And there is every clinical department within this housing here. This is the operation theater with more than 25 operation rooms. This small building here behind, part of it is the Life Center. So this is the laser and immunological research part, and one part of it is a laser research laboratory. So in practical, we need roughly 5 minutes when the medical doctors are calling us to be undressed and dressed, and then we are in operations here. And because of this close connection, we have a direct contact to the operation theater and what we know what happened in this operation, during this operation. On the back door, I always say, okay, on the back door, there are coming some companies with medical technologies. These are laser companies, endoscope companies, camera companies, and pharmaceutics. And we try to make connection on this building between companies and the different clinical departments to make a real translation of the newest development for application for the benefit of the patient. And besides this, we also have collaborations with different universities, institutes, laboratories all over the world. The basic competence of our lab is clinical biophotonics. And there are some other groups in Germany. So we decided to become a group which is specialized in minimally invasive and endoscopic approaches. This is also related that we are structure-wise connected to the urology department. Everything is based on the knowledge about laser tissue action, which every student has to know. Based on this, we are starting to make some diagnostic procedures for clinical applications, but also therapeutical procedures from photodynamic therapy up to thermal laser applications. And for both of that, we have developed together with the companies light application system and light detection systems. And when we put all these things together, we have also feedback systems and sensor systems to be developed for the hospital. From the biological point of view, we are working from in vitro clinical applications. And from the technical point of view, we have our lab devices and prototypes, and together with the companies, we build up some products. Furthermore, we are consulting and supporting the clinical studies and different research projects. Everybody has to know about the laser tissue interaction, and I just want to show 2 slides about that. One of that is knowledge about the absorption of light into the tissue, and this is more or less characterized by the water absorption here. This is main peak at 3 micron, and here we have the CO2. This is a visible spectral range, and normally I'm asking the students, why is this, where do you personally use this low absorption here in this visible spectral range? And the answer is clear. In the eye there, we have a roughly 2 centimeter depth where we can see these different wavelengths and light. Then we have the blood, the hemoglobin absorption here, and melanin, which are the main components of the tissue we are consisting of. And just changing this complete slide into optical penetration depth, we can definitely see that here we have the optical window in between 800 and 1400 nanometers somewhere. We have a huge optical penetration depth. And at that point where we have the erbium laser or 3 micron region, then we have the lowest optical penetration depth. So this has to be known by everybody. The other point is when we apply some light to tissue, we apply normally some irradiance, so in watts per centimeter square, and we apply this for a certain time. When calculated, this is the irradiation in joules, so the energy we applied in joules per centimeter square. And then when we look at this line, this is a 100 joule per centimeter square line, and depending on the factors time and irradiance, we can induce different effects on the tissue, like biostimulation with low intensity or low irradiance, but long times. Then also photodynamic therapy is a non-thermal action, so also low irradiance, long time, and then we start with coagulation, vaporization, ablation, and disruption. And on this side, we have very high powers and very high irradiances, very short application times. So this is in the range of the pico and femtosecond laser regime. The outline of my talk today would be about the stone disease, and then I would like to talk about the mechanism, how we can destruct it with laser, and I will show you a little bit about the destruction measurements, how we make this repetitive measurements, also with the propulsion, which is a problem in stone disease treatment. Then I will show you some laser and feedback systems. I will show you about collateral damage, and I also would like to show you some new technologies. What is about the development of urinary stones? Normally, when we have an increased excretion of stone promoters like calcium or oxalic acid or cysteine, then we can develop some stone. Or we have reduction of stone inhibitors like citrate and magnesium. So the change of the acid content in the body strongly is related to this kind of disease. So hyperexcretion and also supersaturation follows by crystallization, and this normally happens within the kidney part here, and then it was starting to travel through the ureter down to the bladder, and sometimes we also, if you have very tiny stones, then you can rinse it out by micturition. Sometimes this stone block here the ureter, and then it is possible to get pain, and then the medical doctor unneeded. So this is what a medical doctor would like to do. First, you make an X-ray, and then you can see here clearly this stone. It's very nearby the spine, and also you can see here in CT there is a stone located in the kidney part, or here in the kidney part, a little bit further from the spine. Nowadays, we are working with ureteroscopy and laser-induced stone lithotripsy. And from the urology community or society, they have a stone-free. When we use this kind of technology in this area, up to 80%. Stone-free rate here is up to 100%, and if the stone is here, also up to 100%. And here on the extracorporeal shockwave lithotripsy, we already mentioned about that. The stone-free rate is much lower. And when I go back to this way, if you use this extracorporeal shockwave lithotripsy, the focus is roughly in between 1 to 2 centimeters of this thing. And if you're sitting in this application system, and here is the stone and this is the spine, and you shake a little bit your body during the application, then you hit the spine, and also the spine will be distracted by these shock waves. And that is not very lucky for the patient. So with the urological or the endoscopic approach, there is a possibility to use semi-rigid ureteroscopes or flexible ones. This is a rigid one, this is a semi-rigid one, this is a flexible one. And normally we have endourological tools like forceps, domias, and catheters. And we can do also through rigid ones, pneumatic and electrohydraulic applications to distract the stone. Or at the very, very end, we also have the laser system, which is likely to transport through flexible endoscopes. How does it look like? Here you have the urinary tract from a man, as you may see. And the journey around this is we are going through the penis. Now it's more like a roller coaster. We are roughly about in this area. Then we go down in this area with a rigid endoscope right now here. This is the prostate gland here, and you can see here on the right-hand side also the prostate gland in this. And this person, you can see the prostate glands squeeze the urethra a little bit, and then we have to push with the endoscope, the rigid endoscope, through this area. This area should not be harmed anymore because this is for the ejaculation reasons. And then finally we reach the bladder. And then within the bladder, we can see there is a catheter, and this is the way we have to go up to the ureter, up to the kidneys. So the kidney from the bladder is a long, long way this way. And once there is a stone in this area, we use the endoscope, a flexible endoscope, and looking for this endoscopic approach. Here we have a domina, and this is how a domina is working. The domina is introduced through the working channel of the endoscope, and then the stone is fixed in the domina, and together with the endoscope, it is retracted from the whole urethra. This takes a long time. And as you may see, also the stones are very sharp, and potentially there is a possibility to hit the border and the lumen, and then you can get further problems. Here are some stones located in the urethra. This is before laser lithotripsy. After several shock waves, it's still there, but after more shock waves, here it is after 80 shock waves by means of the laser, not by the extracorporeal shock waves, then it is obstructed. And here you can see the bed is a little bit red because of some blood and so on, but normally it is free of the stone. That is the aim of each procedure. Here you can see how it looks like when you use laser pulses of 2 to 10 microns pulse durations. And this is a fiber, this is a stone in the urethra, and you can see that the stone is jumping around. This is what we call propulsion or retropulsion, depends on the country. And this is not very lucky because the medical doctors needs to chase the stone, and sometimes it's jumping into the kidney in the back, and then they really have problems and trouble to find it in the kidney. If you use pulses which are longer than 250 microseconds and in the milliseconds region, then you can see clearly here the destruction is very, very slow, but the stone is in this place. There is no chasing. And that is what the medical doctors would like to have. So on the other hand, to treat kidney stones, it depends on the stone composites. Here are several composites, and you can see they are of different color and also of different shape, and also the structures. Some are very, very structured as a shallow, and others are like crystals and so on. So, and this is dependent on the hardness of the stone and by the very, very end, what kind of laser you should use. If you use this dark colored one, if you want to apply laser illumination on this dark colored one, you can use visible lasers. This is in former times the Alexandrite laser system, or also frequency double Neodymiac lasers emission, and also Neodymiac lasers. Unfortunately, this kind of stone and this kind of stone and this kind of stone cannot be destructed with this kind of lasers. So, and then they came up that in every stone there is some water. And if we use the water as the aimed as a target, which we want to excite somehow or to vaporize that there is tension on the stone, then all stones can be covered. And therefore, the medical doctors, or specialists in development, starts from the visible laser systems up to the infrared laser systems. And nowadays, the whole Neodymiac is a driving horse. So what about the mechanisms? So I already told that we are in this region here, and we are very high temperature, can be increased, but this should be done in water. Normally, if we have a short pulses, we can use the laser-induced breakdown at 10 to the power of 11 watts per centimeter square. There is some ionization, electrons get accelerated by the laser field, and then we have an optical penetration due to this decrease due to plasma shielding. So what happened during the laser pulse? So we have this laser-induced optical breakdown here, but the pulse goes longer, and that makes heating of plasma in front of the stone, and then we have an emission of a shock wave. So, but for this, we need pulse durations of smaller than a couple of microseconds. We create first a vapor bubble here. This vapor bubble expands somehow, and then the vapor bubble collapses and induces during this collapse a shockwave front. And this shockwave front have a very, very high power and a very, very high pressure. And when this shockwave hits the target, or the stone in this case, then we can have a mechanical destruction. This is how it looks like. We have a high energy shockwave, which comes up here. Then we have some tension due to the reflection also on the backside, and then the stone becomes fragmented. This is how it looks like when this kind of lasers are applied to water. Here, this is a fiber tip here. Then this is a time range here. The bubbles grows up to a certain level, up to here. Then it collapses a little bit. This is not the shock waves, this is just a vapor bubble. And then here you can slightly see that there is in red the shock wave starts. And sometimes after this collapse, also we have a new or a second bubble because of the energy. The energy also is so high that there is a further expansion and a new secondary bubble evaluation. This is how it looks like. We have first a bubble, then the pressure waves collapse and induces the the shock wave. This is a shock wave. Here, the shock wave one. No, this is a pressure wave because of the collapse of the vapor bubble. And then once the bubble is really collapsed together, then we got the shock wave. And this is very ball shaped because we have a real center, and you can see very clearly that it is much more faster than the pressure wave, yeah, it's much faster and has a much higher pressure. And as a picture for medical doctors, I always say this is like we put some water or some milk into your coffee, and then we have this wave going outside, and from the coffee cup, the wave comes back, and then we have this beating up. This is a high pressure which hits to the stone, and then the stone can be fragmented by this high pressure. So there is another point when this is a stone. This is the and this is the vapor bubble right now. Then the vapor bubble is sometimes attached to the stone. The red light here is from the pilot laser, and here you can see that it is more attached to it, and then really it is not going free, but the whole energy is attached more and more to the target here, and here sometimes from there is a water jet coming in. The water jet also reacts with the stone and makes some fragmentation process. So the fragmentation normally can be looked like this. We have ionization process, it's very, very high temperature. Then we have the thermal boundary conditions here. We use a shock wave, secondary shock wave, first shock wave, we have cavitation bubble, and then we have also this water jet. But this is in principle a stochastic process and can be used with nearly every short pulse laser system, also with the visible. So, and when we are thinking a little bit more in that direction of the infrared laser, so the 2 microns, then the laser pulse is completely absorbed in the water, and that's something like a Moses effect. So this is a fiber, here is a bubble, and then the bubble expands a bit, but part of the laser energy can now couple directly into the stone. And then the water in the stone is heated up, vaporized, and then this pressure by vaporization follows the destruction of the stone in this very, very small manner. But for this factor, we need longer pulses. This was investigated by Nate using the thulium laser systems, and they clearly can show that this is a native stone here, and you can see in air you have carbonization on the stone, and even in water you have some carbonation and also some melting of the stone, and that was shown on different kind of stone composites. Here it's again, what you can see here is very, very clearly that we have this a little bit melting here, but the crack itself, so the water, the embedded water, acts as a dominant absorber. So the heating and vaporization of the embedded water in pores is much, much intensive. So we have tiny fragment. We can get tiny fragments from the stone, and these tiny fragments did not jump away, and they can be rinsed out by the normal urine maturation process. So we have in principle 2 processes here. One is a photomechanical ablation here, what I showed you. Photomechanical is fragments, fractures, and dissociation. And on the other hand, we have a photothermal ablation, where the expansion of the water vapor within the stone is used for this, for the fragmentation or for the destruction of the stone. But all this is a little bit dependent on the vapor bubble dynamics and on the duration of the vapor bubble. Here, as you can see, short pulse, this is 300 micron, and this is a long pulse, this is 1000 microseconds. And you clearly can see here, okay, this is the maximum which can be arrived, and then it's collapsed in front of the stone. In case of the long pulses, you can see there is first this is vaporization, then the energy of the laser is then transmitted through this first bubble, and you get a second bubble. When we follow it, we can punch the second bubble as well. So we have an ellipsoid or longitudinal bubble, not that odd shape like here, and then it collapses again. This can be evaluated, so this is more for the students, and my students evaluated this bubble dynamics a little bit. We look about the size and the volume of these bubbles, and then we checked about the time. And if you use this short pulse, so in the 300 micron second regime pulses of the Holmium, then you have this first bubble, and then there is a lower second bubble, and potentially you can also have a third bubble. And in this case, you have a low first bubble, and then a large second bubble, and potentially a third bubble as well. This is how it looks like when we look for some movies here. This is a bubble of 300 micron, and this is a bubble of 1 millisecond. You clearly can see the length is much more than here. And this is in free water. And if we do it with a target, this is a beagle stone target, and clearly see how it works here. And here you have enough time during this millisecond to apply a lot of energy directly into this to the stone water in the pores of the stone for this tiny ablation possibilities. So as you have seen, the reach of these different pulses is different. And with regard to this, we tested also this on pico stones at what distance we can see some effects on the stones. And using short pulses with long pulses, you can clearly see that here the distance is 2 millimeters or 2.5 millimeters. So we can see roughly effects, but at 3 millimeters, so we have the final effect on the long pulses. So the reach is much better. And on the other hand, also the different ablation within this target is also slightly different. Here we have roughly 2 millimeters in contact, and this is 1.12 millimeters in contact when we have the short pulses. And when we go down to this at short distances and at longer distances, you can see this difference as well. Then we can have more ablation craters. So it is a real find to have some students who makes all these investigations on fiberstone distances, about the length and the size of bubble formation. And this brings, due to publications, this brings the companies up to make something like a Moses effect. What is a Moses effect? The Moses effect is well known since lithography is introduced. That is a part that the first part of the laser energy is used for the vaporization of the bubble, and the second part, is used for transmission into the stone. And when Moses went from or leaves Egypt, then he also makes this Moses effect. So the water is beside, and he with all his colleagues and went to Israel. So how it happens here in the industry, they build up a tiny pre-pulse And through this tiny, after this tiny pre-pulse, they bring a second pulse, which is much harder and have much more energy. And then they go through the channel, reach the surface, and then they have this ablation possibility. And the Moses effect is a real PR wording right now and spelling, and everybody wants to use this Moses application. But we did it for long pulses since many, many years. So here you can have a look on this Moses effect as well. I will go up here somehow. On the top, you can see a bubble formation without Moses, and here you can see what happens with the Moses effect with a much, much longer reach than here. And if we go in this direction, you can see that if you have this non-Moses application, then the stone jumps away, and using this Moses application, smaller fragments, and the stone leaves in place. This is what we have seen at the very, very beginning when I showed you the post, the two different slides and movies for this stone fragmentation. So we have to stop this one. So let's go for a little bit for destruction and propulsion. What can be developed there? We can really measure the propulsion. Some years ago, we developed something like a pendulum setup, like this. And the pendulum, for the pendulum, we have some iron or some plumb here. And then we put the fiber here just in front, and then based on the force or the impact, we use here that the pendulum deviates, and we can measure it and can then calculate the effect. This we have done with short pulses and long pulses, and also with different energies and so on, and we can clearly identify that the deviation relates to this laser parameters, and also in combination with different fiber diameters, which are used in clinical, either the 350 micron fiber or 200 micron fiber. You can also see this kind of dependencies. So what we know is, or what we get, is that retropulsion decreases. Unfortunately, due to the laser operation, we just can get, at this experiment, we can just investigate the first pulse of the laser, because pendulum do not stay stable in the same position at that time. So therefore, we measured it for different kind of laser systems right now, and this is a deviation. It's different a little bit for for different energies here. Small deviation, more deviation depending on energy here, and also we can calculate the velocity, and so the starting velocity of this pendulum. So, but we want to look, because the regulation of this kind of laser and the clinical applied lasers starts with the first laser pulse, which is emitted. Therefore, the first laser pulse is not the truth. What we did is we put our phantom stones here within this kind of cylinder here. The laser system and the fiber comes from the bottom, and we push from the bottom the stone upwards due to this pressure wave. And that we recorded with a fast camera. And then we track the stone. We can see clearly this up, how it is moving. And then we can clearly identify the up and down movements of the stone. And then we can calculate the deviation of this, or the upwards velocity of this upwards, during this upwards time. And with this, we have a lot of frames here and a lot of pulses, and then we can average. And then we have a mean velocities of more than 100 pulses. And yes, with these multiple pulse propulsion measurements, you can clearly also see that it depends on a little bit of energy. If energy is high, then we have more propulsion. If the pulse duration becomes longer, then we longer is lower propulsion than for short pulses, but the repetition rate doesn't matter. So, but there are some, when we discuss with the students about the pendulum, single pulse, and the video tracking system a little bit, and there are some weaknesses and strengths on both sides. And this is just to show that every time we have to reconsider our experiments to make more proper and reproducible experiments overall. And then we started with the ablation process. And here also we started with several fibers and different parameters on the laser side. Here is a BIGO stone, and then we fire one pulse to this BIGO stone. And we measure it with optical coherence tomography. We try to measure the depths of it. And then we calculated the topology, like depth, diameter, area, volume, etc., and make some statistic about that. And this is how it looks like. If you have a short pulse laser here, and it's 300 microns, 350 micron, then you have in a sagittal view with OCT, you can see this kind of depth and crater. And here you can see what happened if you have a long pulse. Interestingly, on phase view, you can also see different structures on the bottom and on the surface. And from this, you can calculate and you can see the differences. And what you can see is that the ablation volume is roughly similar on one pulse for certain, for the same laser parameters if you use different pulse durations. So, and if you look just for one pulse, you have the same problem as in the pendulum experiment. So we were thinking about how we can use multiple pulses. So we make a similar cylinder like in the like for the propulsion experiment. We put the stone here inside this volume underwater. The fiber comes from the top, and here we have bore holes which are roughly 2.5 millimeters in diameter. And we know that every stone compartment which falls through these boreholes, these are fragments. And we can measure afterwards the fragments, which are smaller than 2.5 or 2.3 millimeter in diameter. And when we calculate the weight of the fragments, and we know about the stone mass before, and we make a subtraction, then we can get something like a dust, and this is what we cannot really catch in this water area. So we do this, so we sieve it with meshes and so on, and dry it, and we have the same conditions as before, and we measure the time when the first stone breaks, first time, then the total application time, and when we make a subtraction, then we have the time after break as well. And from the mass, we do the same, what I already told you. So with this, we can see for different conditions. This is laser parameters, 1 joule and 10 hertz, 0.5 joule and 10 hertz, and different possibilities of pulse duration. Then we can clearly see that the time until break changes. And we take this time because once the stone is breaking, then the chasing starts. We need to chase two different compartments for this. And with this regard, if we have short pulses, it takes much longer to get these two parts really destructed in case of having longer times. Yeah? And also the destruction during this time is much higher. So we calculate, the calculation of the masses is that we have roughly 70% in dust, so fragments smaller than 1 millimeter. And in this case, the dust is low compared to this. And the fragments is of sizes of roughly 2 millimeters is lower here compared to that. And this is similar to that what we found also in the lower energy application. So the experiment shows that the fragmentation probe says that fragmentation goes up if the variation for the energy per pulse goes up, and the fragmentation time at the very end goes down. And if the pulse duration goes up, the fragmentation time takes a little bit longer. With regard to the propulsion, okay, if we change the energy per pulse up, then the propulsion also goes up. If the pulse duration goes up longer, the propulsion itself goes down, and the repetition rate doesn't make any effects. So now let's go a little bit further for the lasers. So here I show you old laser system. There is on one hand side the Freddy laser. This is a frequency double dual pulse Newton-Young laser. So this laser uses the red line and also the Newton-Young 1046 nanometer lines for fragmentation. The flashlight pump diode laser is working on nearly 600 nanometers. And then we have the Holmium-Young lasers, which is a trading horse right now from different companies right now. Luminis and so on are also further companies. But these two have something like tissue stone differentiation technology. And I would introduce it like here. This is the pulse shape of, this green one is the pulse shape of the frequency double pulse. And this red one is a pulse of the Newton pulse. If the green pulse reaches the stone, then this bubble is formed due to this ionization process and so on. And this is pumped by the infrared pulse as well. And then we have a really hard shock wave directly in front of the stone, and the stone can be destructed. In case we have some tissue in front of it, then the green light just penetrates through the tissue. There is no bubble formation in front of it, and also the infrared light just penetrates into the tissue. Then nothing happened. So this is more or less a passive differentiation between tissue and stone. Using this flashlight pump dye lasers, they have had a different approach. They have the laser pulse here, and they detected the remission of the stone, or if in front of the fiber there is tissue. And as the pulses are roughly 500 or 800 microseconds long, then the detected energy here is analyzed by a signal analyzer after 2% of total energy application of this pulse. And then if the analyzer said there is tissue, then the controllers shut the optical switcher here, and only 5% of the total energy is applied to the tissue. In case there is a stone in front, then the controller says, okay, we leave this open, and then the full pulse energy is applied to the stone. For the Holmium-Young laser, nothing is on board like that. As we are a laser lab, we put some stones under a fluorescence microscope like this, and we shine some light on it, and we have some decorated mirrors and so on. We have also some spectrometers here, and we look through the camera what happened to this urinary stone. What happens? If we excite roughly with 400 nanometers in this line, you can clearly see some fluorescence here in the blue range, starting in the blue range from 500 up to 700 nanometers with a nice spectrum. If we illuminate more into the blue-green region, 550, we also have similar things, and you can see a nice stone. And if we use 550 nanometers for excitation, then we see similar, but we have also this red fluorescence. What can we do with this? Fortunately, we have in the operations theater for urology, we have a white light lamp for the retroscopic approaches to look into the bladder. And due to our investigations and developments based on tumor detection within the bladder, we did it with blue and also with green light, the illumination. So this was a switchable light source. And then we asked the medical doctors to use this light source source also for this fragmentation process when they make lithography, laser lithography. So switch between white light and different excitation light. And then we need also on the detection, we need a filter on the ocular of this endoscope. And then we also have this filter technique and we put it on this ocular. This is what we can see. Under white light illumination, here on stone sample number 1, we can clearly identify this cystine stone. You can see the surrounding tissue. We can see a procedure like this. When we switch on just green light, we have the fluorescence of the cystine when we did this detection of 610 nanometers and more. Low fluorescence on the surrounding tissue, no fluorescence of procedures. The same is here, much more clear. This is the stone in white. This is the tissue. This is the procedure. And under fluorescence vision, you clearly can identify only the stone. And this procedure is now on the way with companies together that if there are some fragments somewhere in the urinary tract, then we can find it probably by use of this fluorescence technology. What should we know else? So during this kind of applications, we use fibers between 200 and 600 microns. With newer lasers, we can also reduce it to 100 micron meter fibers. And light emission is more or less in the actual way with a numerical aperture. It is similar in air and in water. Unfortunately, there is a random process when you work on stones. Fragments hits this fiber tip, and then you have something like angel or whatever fibers here. You do not know what happened here in front. Sometimes it looks like this afterwards. This looks a little bit like a side-firing fiber if this would be air. And due to this, we have some fiber burn back. And yes, the students also have the possibility to make this fiber burn back. They like this kind of experiment. And yes, it is different when you use short pulses and long pulses. Short pulses and long pulses for different applications. But what is more interesting is if we put laser light, Holman laser light into this fiber, we have to look about this bubble shape. When we started with a bubble shape, it looks like here. So we have something deflecting in this direction, some deflection in this direction, and so on. So the energy disappeared in a different direction. And we can calculate it also by ray tracing if we think about a side-firing fiber here. What can happen if we have, we can have a look on the thermal impact on a real good bare fiber here. This is something like an agar gel, and we can clearly see here the bubble shape. And we can see here nicely the temperature profile also within this agar gel. This is the lumen of what we call artificial ureter. So if we have an angel fiber tip, then we can see, oh, we can hit we have a shock wave which transmits or which is moving into the tissue, and hopefully it is elastic enough that nothing happens. But when we look at the temperature profile, all the energy is going into this direction, and then we cook it. And that is what the medical doctors don't like, because cooking a urethra is like perforation, and perforation they don't like. And ruptures are the worst case, and ruptures take often place when they are chasing the stones with their endoscopes. They don't like it. But we can also have a look to other equipment which is in this area. So there are some catheters in this area, and we can hit these catheters and can destruct it. Like this is a three-handed gripping pillar, and you can see this is nitinol material processing somehow here with laser pulses, which is not useful, and also guide wires can be distracted by this way. And if you do it on tissue, exactly, you burn holes into the tissue. And this is a movie in which also this feedback systems or this maybe fluorescence guidance is a nice indication there. It looks like that the medical doctors is dealing and working only on the stone, but there is a nice catheter, and he didn't realize that there is this catheter, so he was spending a lot of his time in destructing this catheter. So now let's come to new technologies. We have spoken about lasers here in this region. This is the visible region and the iliac region. I also spoke about the Holmium wavelengths in 2100 nanometers. But let's have a focus a little bit in this wavelength range, where we have a local maximum of water absorption. This is this one. And this can be achieved by thulium lasers, which are nowadays available, and they are available also as thulium fiber lasers. So the water absorption is increased a little bit by a factor of 4. So the penetration to hit some tissue is much lower. So because the optical penetration is 1/4 of the optical penetration of the Holmium lasers. So furthermore, when we compare Holmium lasers to thulium fiber lasers, then for low power generators, we have one optical cavity here, but this reaches up to 30 watts. And the pulse duration is related to this, to the pumping of the laser. So, this is roughly maximum 500 microseconds. For long pulses, high power generators needs 4 cavities, and this needs to be put into one application fiber. Thulium fiber lasers can be pumped by diode lasers without any optical components inside. And thulium fiber lasers have a core typically of 10 to 20 microns of the fiber, and it's easily coupled here into the application fiber. Furthermore, because we have diode, it is a diode laser driven process, we can really make rectangular shapes of the pulses, and we can make pulse shaping in different manners. And at the very, very end, when we look at the beam profile here, we have here this large beam profile of 300 microns in diameter. Therefore, we cannot reduce here the fiber core diameter less than 4 or less than 200 microns. With this, we have a very, very nice shaped Gaussian profile of this laser beam, and which can be focused into fibers of 50 microns so far. We did experiments with these new laser systems on the fragmentation process and also on the propulsion process on different parameters. And that is what we learned there. Yes, we have these curves. Here is the break time, and then we have this chasing time and destruction time. And we found some best settings as well as in 20 watt regime, but also much more better in the 40 watts regime. And we found also that the destruction is very, very high, especially the dusting is very high. So related to the different kinds of parameters we used here, we have in between 70 to 90% of dust. So just roughly 30 to 10% fragments. So, and finally, we also checked the propulsion, and we clearly can see here that using holmium laser system, different kind of holmium laser system with different kinds of pulse duration and so on, the velocity we measure is in between or more than 100 millimeters per second here. And using the thulium fiber lasers, we are really stable in the range of 60 millimeters per second, plus minus 5. So in summary, we can say that this laser-induced shockwave frequency is individually dependent on the lasers used and the choice of the parameter. We can destruct the stones. It is a very efficient way, much more efficient than the extracorporeal shockwave lithotripsy. And in principle, it can be done with each laser. But we need also efficient in destruction of equipment as well. And I know some medical doctors who have some problems with their forceps because they were broken somehow, and then they go with a second fiber to this region because they cannot retract the forceps, and then they destruct the forceps with the laser, then you can remove forceps. So this is also positive as well as negative in terms of use. And there are still new innovations in progress right now for this new kind of thulium fiber laser applications. With this, I would like to thank you for your attention right here, and also my colleagues, Max, Thomas, Frank, and Stefan, for working on in this field for a long, long time, and several further internships, bachelor and masters. So if you have any questions, then ask.
Thank you. I think that speaker will pick me up, and people from Zoom can hear me. So if you're a student and you have a question, please feel free to go ahead. In person goes first. Here.
I have a few questions then. I'll go first. Well, first off, great talk. I really enjoyed it. One question I had was for the visible laser applications. Like, is that then just purely focusing on like thermal effects destroying the stones, or?
No, this is more the ionization.
Oh, okay.
Because visible light is absorbed by the stone.
Right.
And because it is of high energy, then on the outer shell layer, there starts ionization.
Okay.
And then we have the plasma, and the plasma then is pumped by the rest of the laser pulse. And when plasma collapses, then you have an immediate effect on the stone.
I see. Okay. So okay. All right. That makes sense. Okay. And sorry, I'm kind of jumping around the question, but I saw that with a few of the studies that you showed with stone model that you used a 15:4 mix to water ratio. Sure. What is the significance of that specific ratio? Is that similar to a specific type of stone? Or?
No, it's we checked about the elasticity or the hardness of stones, and this is a medium hardness. It's a medium stone.
Okay. So averaging. Okay. Okay.
And Pico is so that was introduced by us when I discussed with my dentist about this topic, and also my dentist also was a medical doctor student in this field.
Oh, okay.
And then we discussed about what kind of artificial stone should be developed. There were plaster of Paris was used, and then there are some also limestones and corals and so on and so on and so on. And then we discussed a little bit around, and then I asked, we discussed, okay, we need a stone which do not take some water when it is a stone, and which is very highly reproducible and has low expansion normally when it's heated up. And as a dentist, he knows, okay, we have a specific a mixture of this bigo because making this the artificial teeth. Then they use a special this kind of material. Then we use it, it's fine. And now it's used everywhere. In this field.
Sure. On the topic of fluorescence, what is the major fluorophores at the time?
Very good question. So we are not on the way right now. I do not know.
Okay.
We just take this couple of pictures there, and we found what our thought is. There are to use the fluorescence as a guidance for as an observation. We came up from this tracking the stone during its movement by the propulsion process, and then we have seen this fluorescence, and then we thought, okay, we can use this fluorescence through the endoscope. Okay, so this is not the laser, this is the illumination part of the endoscope. Okay, when the stone jumps away, we can track it again. Okay, then we have to change the endoscope and not the laser. There's no need to change the laser system. And that is what we just tested. This is also clinically, we just tested it 1 or 2 times. It's not on the market, there's nothing. So, but it's thought about it. And another problem in hospital is when the medical doctors retract the fiber into the working channel of the endoscope, and there happens some pulse application, then the endoscope is broken somehow. And they have a lot of, spend a lot of money just for restoration of this kind of endoscopes. And each restoration takes about 8,000 euros. From my knowledge, they use it 20 times and then needs some restoration. And therefore, we also can see that, or we have seen that the fiber itself, the jacket of the fiber, is fluorescent. And when we shine some light on it, then we can see it. And if we track the fiber is retracted and we cannot see it, then there should be a beep or something like that, and the medical doctor should not activate the laser anymore. So that is the way what we are seeing. It's very easy to do.
Okay. And then my last question is, especially with the thin fiber lasers, matching, choosing a wavelength that matches more so with the absorption of water. Matching this absorption of water, would we expect more so an overall increase in stone ablation, or do the bubble formation mechanisms and the heating of the water bound in the stone, do those processes?
In this case, we have more the water in the pores of the stone.
Okay.
This is the aim.
Okay.
Therefore, the dusting of the studio fiber is much higher, and we are in contact with the stone. So the bubble formation, or the effect of bubble formation, is a little bit reduced. I see. So it is a very complex way, but we want to make it much more easier for the medical. Further questions?
Thank you. I'll open the floor up to the Zoom audience and faculty.
Cecil, I have a question.
Feel free to go ahead.
I have a question. how does it,
You can
I'd like
unmute
his
his
laptop.
I think the audio in the room needs to be.
can you hear me?
I can do that.
Can you hear me, Cecil? I have a question. How does this method of treatment compare to, say, ultrasound for,
What am I doing?
Don't get it.
Say again, Jim?
how does this method of treatment of stones compare with ultrasound for breaking up stones?
Good question. As I started at the very beginning, ultrasound is applied from outside the body. And then you have this, you need a focus of the ultrasound. See, there are two technologies right now on the market. There are either two ultrasound emitters, and in their crossing, then there you have a focus, and the focus is roughly about 1 centimeter up to 2 centimeters in diameter. There is another option that you have multiple piezos in this bar, and then it is transmitted through the whole body, and the focus is even a little bit larger. The problem is, if you put ultrasound to the body should be connected to water. So you sit in a water bath and you are fixed, very, very fixed. And using CT and X-rays, you are moved within the bath to the focus of the ultrasound emitters, and this focus should be overlaid with your stone. So this is a big movement around. And then you were hit, perhaps the first time, and then you're a little bit shocked about that. You feel it in your body. And then the whole procedure about focusing should be done again. So it is a long procedure, and due to this, and it is an outside procedure. So there is nothing which is introduced into your body. So the medical doctors like to do it more endoscopically. Okay.
So which one is now done more often?
So I would like to go up. You can see the slide. On the right-hand side, you can see the stone-free rate using lasers. And this is, on the right-hand side, you can see the stone-free rate of extracorporeal shock wave lithotripsy. And you can see that this is much lower than here. Also, this one is lower than here. This is about similar in the lower tract. And the problem when the stone is in this area, or even in this area, then more or less in this area, then I have to go one higher in this area, then you're nearby the spine. And if you induce some shock waves, extracorporeal shock waves to hard tissue, and the spine is hard tissue, then you make destruction in this area as well. And that is not beneficial for the patient, and it is not the aim of the medical doctor. With regard to this, in our hospital, so this extracorporeal shockwave lithotripsy was created by Professor Schossi 50 years ago in our department, and now they remove this extracorporeal shockwave equipment.
Did they remove the professor as well?
No, he retired. He was retired. So also removed, more or less.
Dr. Kumar?
Yeah, so I was wondering, since
obviously, probably it's for dental drilling, can this be substituted? Because, certainly the sound of a drill go there. And since it creates dust typically, which also the drill does.
Mhm. There are a lot of applications also in dentistry using laser pulses. The problem is that the energy used here for the XM3 for the visible spectral range laser is not enough. They more or less use the erbium, so the 3 micro wavelength range, to use it. And with this, you induce a small fragmentation. You can remove caries and so on. It's very, very nice and easy. And also the thermal effect on the tissues or on the teeth down to the pulpa, where the nerves are, is very, very shallow. So you need no anesthesia. So it is possible. And there are devices on the market. Unfortunately, the devices are highly expensive. And it takes longer than with a drilling machine. And with a drilling machine, you can remove some caries. If this is a cavity, and you go a little bit, this is the way where you drill in, then you want to remove something here inside, then you have no chance with a laser beam right now. And therefore, there are some dentists who got this kind of device, but it is not common. It's not really accepted.
Yeah, another question I had was, you showed some damage to the fibers, some of the fibers, right?
This is not damage to the fibers, this is damage to equipment, this is guide wires.
Okay.
And so on. Yeah,
Yeah, but so the optical fibers, do they at times get damaged due to, say, nonlinear effects like self-focusing or something?
no, this fiber is not. So the damage of the fibers, like shown, like these fractures I showed you, this one, this and there, this is more or less by fragments which were jumping from the stone backwards because of high speed, and in another way also medical doctors are working not very smooth, so they have no time, so
Push it.
they push it a little bit and so on.
So sometimes is there some absorbing tissue on the tip of the fiber, and then they can absorb, and then you can get ablation or something?
That is a good point. Underwater, not.
Yeah, water.
No, underwater.
Yeah, okay.
This happens not. If we make surgery somewhere else, so prostate or on kidneys or wherever, I can show you slides about that, then sometimes the fibers burn. And you get a real hot tip. But if you get a hot tip from the physics point of view and from the optical point of view, you get a real hot tip that is blanket, carbonized, and then there is no need to have a laser on the other side, because a hot tip I can do with radio frequency as well, much more better. Because the hot tip, so the carbonized tissue in front of the fiber or the carbonized end of the fiber is just heating. That you can do with some other energy. Then you do not need a laser system.
So currently, even the prostate resectioning they do with laser, right? Ablate the tissue.
Sure, but in this case, with holmium lasers and with thulium lasers, so in that case, if we are talking about holmium laser enucleation of the prostate, then the medical doctors go through the urethra into the prostate, and the prostate, this is the prostate gland. This is the prostate gland, and the prostate gland is covered by a capsule. And they went with a fiber in this direction. And then they make bubbles, so it is ruptured by this interface. This is no real thermal application or incision of the tissue. So this is more rupturing. And then they do it like an orange, when you put it in, when you put your finger into an orange and chip, and you put all the orange particles out from the inner part. Then here they make some slices, and the slices were put into the bladder, and afterwards you came up with a morcellator, and with morcellator technique, this is a suctioning technology with a knife, and then the big pieces are removed from the bladder. And there is another technology when you use fibers like this, also, which are just firing in this direction, then you can make an ablation here on the surface. This is completely different. This is vaporization and this is enucleation.
Thank you. We have one more question to end today, and that would be Dr. Sejo.
I have another lecture.
Thank
Oh.
you.
We can talk. Okay,
Dr. Sejo.
Yes.
next question.
So thank you for the very interesting presentation, Dr. Sroka. I have a question about the clinical practice. So what is the clinical experience in terms of patients tolerating this procedure and in terms of recovery rate?
In terms of recovering, they go at home the second day after operation. And in our hospital, so the medical doctors, so this lithotripsy application was done every day 4 or 5 times.
Mhm.
I know a hospital in China, and in China, they are working in 5 operation theaters, starting at 8 o'clock and ending at 8 o'clock in the evening. And the whole time they are just making in 4 operation theaters this kind of stone lithotripsy using lasers.
And is this under local anesthesia or how do they do that?
Now you have the possibility either to have a complete anesthesia or this, I do not know how to spell it in English, is spine anesthesia.
Epidural. So they're under
Yes.
epidural.
Yeah.
Mhm, because the catheter and the guide wire need to go very high up in the urethra. So
Okay.
that would be intolerable.
So then you need a total anesthesia.
Thank you.
So and for my knowledge, the guide wire is not always needed for medical doctors.
Mhm.
If you have an experienced medical doctor, then you put the endoscope just into the tissue and into the ureter, and then through the urethra into the ureter without any guide wire.
I see. That also depends on the geometry. Yes.
Sure.
Yeah, sure.
Thank you.
So the endoscope development is really fine. So right now, I think they have endoscopes which have outer diameters of 4 millimeters with a working channel of 1 millimeter, and there is illumination and camera, and all this is included. And in addition, they can bend the distal end by 360 degrees in one direction and another 180 degrees in the other direction. So they can really manage it.
So is there any advantage to using a single fiber or fiber bundles
For what?
for delivering the optical?
This for the energy, you need not a fiber bundle. Fiber bundle was used in former times just for illumination and to get the picture if you have not a video endoscope where the chip is on the tip. Nowadays, there are some single-use endoscopes available, where you have a chip on the tip and just a working channel there. And they are very, very thin. And when they break, nothing happened. It costs roughly 500 euros, this single-use endoscopes. And there is no need for restoration of the endoscopes afterwards. But it depends a little bit on the medical society or the medical insurance of the different countries who pays for them.
Thank you so much. I'd like to thank our speaker. So